Morning. Welcome to the upper GI session. We're going to be talking about robotic surgery for gastric cancer. I'm just going to give you a very brief overview before all the experts in the field actually get up and give a talk about their experience. So where is robotic surgery for gastric cancer today? And we'll just briefly go over that we believe that it's safe and it's feasible, and the controversies about oncologic soundness of the procedure. However, there's some good emerging evidence to demonstrate that we can perform the same operation robotically as we do laparoscopically and open. And there's some few studies out there, most of them not from the United States, from abroad, demonstrating that there is a better learning curve for robotics over laparoscopy for these complex operations. And most of those studies come from abroad as well. You know, there's marked global variation in the experience and the expertise, adoption, and expansion of robotic surgery in each of our subspecialties, and especially for gastric cancer, it's very lopsided to East Asia. And I wanted to raise some questions about where is robotic surgery for gastric cancer going in the future. So in the past, we have one robotic brand that we've been using since the year 2000, and that's the brand Da Vinci Surgical Systems, the SI and the XI that just came out. And the robotic for surgery for gastric cancer was first published in Japan in 2002, and then in the United States by Giulianotti's team in Chicago in 2003. But you can see there's a sort of a slow growth down here of robotic surgery for general surgery. Its application in general surgery and gastric cancer falls into this little pile here that's growing. And you can also see from the peer-reviewed articles that have been out, there's about 1,000 out of the 9,000 peer-reviewed journal articles that address Da Vinci's use in the general surgery, and much smaller portion of this is in gastric cancer. So the evaluation of robotic gastrectomy has been fairly new and few. And if you look at the variation, the case series that came out with initial experiences in Japan in 2002 and 2003, and then an abundance of, I guess, disproportionate number of case studies and comparative reports, and a multi-institutional study that I'll review pretty quick later came out. So if you look at the total number of patients in these studies, definitely there's, Korea has been on the forefront of this. And then it also, with China coming out recently with a robotic application in gastric cancer, you can see that they have one comparative study, and this reflects their volume of cases that's in China. And the smaller number of, we have in US, we had 2 case studies, no comparative reports, and a total of 107 patients. So this sort of reflects the volume of gastric cancer that is surgically resected in the United States versus in East Asia. And Italy has always been there with 3 comparative studies, 2 initial case series that came out, and it's about 100 somewhat patients. So we've seen all of this before, that for the patients, robotic surgery for gastric cancer has advantages of MIS. Less blood loss, we've heard this over and over again, decreased pain, and definitely there are advantages to providing our patients with minimally invasive approach. And when compared to laparoscopy, robotics definitely has comparable complications and lymph node retrieval, indicating that it can be an oncologically sound approach. And then, of course, with laparoscopy and robotics compared to open operations, we know that there is a longer operative time, and we hope that it can maintain oncologic parameters. And that's really, I think, surgeon dependent. And then we have some promising long-term outcomes. And for the surgeon, there is a perceived enhanced operative environment that if we use the robot, it will help us in some way because the technology is better. We have the operative view that's better, 3D. We can capitalize on the precision of the dissection. The articulating instruments compared to laparoscopic straight sticks give us a way to get around angles with the precision. And the combination of all these three, we perceive that it would be a better operation. But when the studies are done over laparoscopy, they're very comparable, and the advantages are not realized in patient outcome. And then, always we have a reliable assistant with the robot because we can control the forearms. And then there's some studies to show that there's a better learning curve. So if you look at the studies, we know that the D2 dissection that is recommended for anyone with locally advanced disease is well recognized to be technically difficult, and the studies on open and laparoscopic surgery actually demonstrate that this has a high learning curve. For subtotal distal gastrectomies with D2, it is well known that about 40 to 50 cases are required to overcome the learning curve. This is a really steep learning curve for most of the surgeons in the United States to achieve in a short period of time. And a total laparoscopic total gastrectomy, one of the studies came out, and it requires about 100 cases to become proficient and provide our patients with the best outcome. And these are the studies that came out on the learning curve, and this is a method of analysis. And essentially, the robotic learning curve, from whichever way that they evaluated it, seems to give us a shorter learning curve, meaning anywhere between 14 to 31 cases. And this is shorter than the laparoscopic learning curve. And so if you look at the early adoption and expansion, it really came initially from South Korea, although they were not the first to perform the robotic cases. And the largest single surgeon experience is from Dr. Hyung at Yonsei University. I mean, this is a large number of cases that he performs and teaches. And then the largest single institution volume also at Yonsei with over about 948. And this is over a period of 9 years. So a quick expansion. And we know that there was the first multi-institutional study that came out from South Korea, meaning there are 17 surgeons from 11 hospitals who are performing robotic surgery as well as laparoscopic surgery. And the conclusion of this study was that 185 patients versus 185 patients in the laparoscopy group, pretty much equivalent outcome, and then it costs more. And so how does that translate to us? In the United States, well, Dr. Julia Anati's group at the University of Illinois published their series over 10 years, and that's 98. It's almost like 10% of Korea. And they did a 5-year survival, which seems to be fairly comparative to open and laparoscopic, other studies. And this is within the context of their larger robotics program, not just doing robotics for gastrectomy, like some of the Korean hospitals and surgeons do, but they perform other operations for other disease processes, the same surgeons in the same group. And then Dr. Pagazzi and Ellenhorn, who used to be at CDFO, published their first series of 7, and I think there was another series of 11 over a period of 4 to 5 years. And then, Dr. Putsawan, who is one of our chairs, actually has an unpublished, he probably has the largest case series that's not published yet in New Jersey. And then my experience over 3.5 years, about 36 cases, which I'm evaluating now. So it's a small number. And this actually, the limited expansion in the US is very indicative of what has happened when they did a study of the US National Cancer Database, which captures about 70% of all new cancer cases. They found that, in a period of, I can't remember exactly, but in a short period of time, there was, in 2011, I think they evaluated 2,634 patients who underwent curative resection. Most of these patients had stage 2 and 3, and what we found was that only 12.6% of all of the gastric cancer operations done in the United States are being done laparoscopically, and even among those, or minimally invasively, and among those, there were 24% open conversion. Another study that was done evaluating a 5-year period, 9,597 patients in academic institutions, 90% of these were open cases, and 8.2% were done laparoscopically, and a very small percentage. So we're in our nascent stages, and sort of it reflects the volume of cases that are done overall in the United States. In 2007, only, I think it's 2 hospitals in the US had a volume that was greater than 100. And this also reflects the history of City of Hope, the hospital that I just moved to, who has a very, very robust robotics program. And they were one of the pioneers in robotic surgery for urology. They published a lot of papers and were committed to surgical innovation, and in the period of 11 years have done 10,000 cases. But if you look at general surgical oncology, it's like 4%. So sort of we're in the beginning stages of using robotics for our procedures. Oops, sorry. And so in order for us to expand robotic surgery for gastric cancer, I think there needs to be a commitment to surgical innovation like we have at City of Hope, and I'm sure the programs that you come to and the fact that you're here at CRSA have this. The strategy to grow and integrate robotics into the treatment of gastric cancer overall, and then really finding out what patients will benefit. This is still under investigation for us because we don't have high volume to do these great cases, and we want to aim for high volume so that we can have some patients who will benefit from this. Currently we have about 100 cases per year of robotic cancer operations, and you can see that it's a very small percentage that's being done robotically. And this is all going to be done within a larger surgical oncology robotics program with pancreas and liver and colon. And we need continued critical evaluation of our outcomes to see if we are in fact benefiting our patients. And I believe that we need collaborations with other institutions and global leaders for us to be able to do this properly. And so this is sort of where I want to raise some questions about how will we define the role of robotics for our future, for our practices and our integration. What are going to be the real indications for us? Right now it's early cancers, locally advanced cancers. Patient selection, what will be the best patients that will actually benefit from this? How are we going to train our fellows and residents to do a robotic gastrectomy when you only have 10 cases a year and maybe only one of them are being done using the robotic approach? And, Dr. Hyung and the Yonsei group standardized their procedure, and are we going to be able to use that standardized procedure to apply to our patients? What about the qualifications? I have more questions than answers right now because who is qualified to perform these operations, and how do we deem them to be safe enough to do a procedure? Is it going to be 10 robot cases, any robot cases? Is it going to be 20 robotic gastrectomies? And what about the cost effectiveness? Because some studies say, well, the cost effectiveness evaluation really has to incorporate all this insurance issues that we have, and it's very different for all the different countries. For example, in Korea, they have to pay for the robotic approach. For the United States, depends on the insurance and the hospital. The cost does not increase for the patient, so it's a little bit different. And what studies should be performed? What can we do as a group to evaluate this efficiently and see what we really need to go forth from here? And how can CRSA or groups like CRSA, like SAGES, and these larger institutions, and the International Gastric Cancer Congress, how are we going to define the guidelines and the safety for our patients? And so, perhaps we can, the group that is here and those who are interested in performing robotics for gastric cancer, get together to establish an international centers of excellence of robotic surgery for gastric cancer. I don't even know what that would really look like, but and develop a tailored training program for our trainees to be able to perform these efficiently and effectively, and continue critical evaluation of not just this robot that we have, but in soon to come many more new technologies that will be available to us, and how is it going to really help our gastric cancer patients in the overall schema of surgical treatment. And then collaborate to bring all the best surgical innovation to our gastric cancer patients. There are many represented here just in this room, probably many different countries and very different practices that we have. So I want to thank you for your attention. And if, my contact information is down here if anyone wants to collaborate.
Thank you. We will discuss all after all the presentations. So